two on the top. So when you take a look here, missing a bicuspid on the top. Okay, so we've got one bicuspid. You got central lateral cuspid missing. You're supposed to have another bicuspid here. You normally have two. You've got one in the molar. Down here, that's a baby tooth that's over-retained and submerged. This is a baby tooth here. So missing both bicuspids. Now, we can miss a tooth on both arches and still be okay, like I said. But we take a look at his facial profile, and we look and say, well, the lips are pretty good, maybe they can come back a little bit, but we can eliminate maybe one tooth on both arches. Well, this particular woman, she used the anchors and she did just that. But she did it without affecting his lip profile. So if you look at his profile, he doesn't get that recessive lip profile. Now, if you've got a ton of crowding, taking out teeth doesn't necessarily change the lip profile. But if you don't have crowding, which he did not, closing space will definitely retract the lips. Teeth support the lips. You bring the teeth back, lips come back. Basically, the reason why I show this is if you look on this bottom picture, there's an anchor on one side. And this was a European country, I forgot where it was, Norway or something like that, and they have managed care. And basically, orthodontics is free there, but you have to qualify for it. So you got to be really bad to get orthodontics there, but you do get it for free. And this particular patient drove, I forgot how many hours to get there, but they forgot to take one of the anchors out. And they came back 5 or 6 months later, and the bone on the side of the anchor looks better than the bone on the other side. It's preserved the bone, just the tension of that. And so that's helpful for us when we're dealing with people who are missing teeth, because we want to preserve that bone, and so that they can have future implants, and they've got to be able to implant that's the final end result isn't something that can be placed till the patient is done growing. So we're waiting until around 17, 18 to actually put the implant in. If we do treat a child at 12 or 13, we've got to manage that bone in the time being. Now, this is a patient of mine who has, when we take a look at her lower jaw is back. She's got a weaker lower jaw. She's got crowding on the top. You straighten those top teeth, they come forward. You end up with an overjet between the top and bottom teeth. There's different ways to fix this kind of bite. This is the most common skeletal type issue we deal with. Most common is class 2. The least common is class 3, the underbite. And in her particular situation, she's got a pretty good profile, so we reserve surgery, mandibular advancements for more severe cases. With her, we can do it with using some anchors or doing some extractions on top without anchors, and wearing a whole bunch of rubber bands, because these back teeth are right where I want them. I don't need them to come forward. So if I'm closing space here, I'm using these back teeth. They're coming forward while the front teeth are coming back. Everything's moving. And I have to back it up with rubber bands, and it's kind of compromised because I can't get the pure movement that I want. I just want the front teeth to come back. I don't want the back teeth to move at all. We can use springs, which I use quite a bit. They allow me to treat patients non-extraction, but they're bulky, and I gave her the choice. And when she looked at it, she said, I don't want to use those springs. They seem medieval. So we did extractions on her, and we used anchors, so she doesn't have to wear any elastics. So the anchors are what we're using to bring. She's still in treatment now, so I can't show you final photos. But basically, we've got the anchor here, and we're using it just to pull the front teeth back. So the back teeth here don't have any force on them. They're not moving. Here's another patient, and this one's one that's limited treatment. She really needs to be full treatment braces. If we look at this x-ray over here, she's got an impacted tooth here. She's got an impacted tooth up here. And this is a difficult 3-year case, but she doesn't want to have braces. And the only reason why she's doing it is because her dentist told her if she doesn't upright this tooth, she will lose it. And that is true. She'll get decay down in there. She can't clean it. She'll lose that tooth. And so she wants me to upright it, but she doesn't want me to use braces. Well, you can't do that with retainers. And the fact is that I used an anchor and just limited braces to do it. But basically what I did is I put an anchor in between these teeth here. And I used this lower lineal arches so that I had width control here, and then I had sectional wire that went here to bring this, took out the wisdom tooth and uprighted this. Now this anchor, when I first put it in, she felt pressure on that tooth. Basically, to put the anchor in, your bone does not have feeling. Your gum tissue does. So all you have to do is numb up the gum tissue to put an anchor in. And Some people will do it just with topical. I'll use the smallest needle and just do a little welt, like a little mosquito bite of anesthetic right there in that spot, but the teeth aren't numb. So when you put the anchor in, they start to feel pressure on the teeth. You know you're too close to the tooth. You can't really damage the root when you could scar it, but it's going to heal back. But basically, she was feeling pressure on it, so I took it out, moved it forward to that spot. So basically, I went in a little bit different spot. And I used that, and you can see over the course of 16 weeks, that tooth is upright. So we go from up here, impacted, to better, to upright, and she got her braces off shortly after that. And basically, the anchor here is just to keep these teeth, this segment, from moving while I'm upright now. So I possibly could have done it just from the anchor and not had anything else on there, just the anchor and that tooth. And that's kind of where she ended up, limited treatment. That's Cal Parker, and that, I think it was Wake Forest game as well, but you can see the reflection in the end, kind of thing about reflections. So, yeah, that was kind of cool. This is another patient, same kind of thing, basically orthodontics. You look at it and you say, okay, wow, she's missing teeth up here. She's got space on the bottom. Can I close that space on the bottom? Well, I would, but I have nothing to pull back from here. So if I close space on the bottom, her bottom teeth come back, she ends up with a big old lower jet. So I've got to be able to close space on the top. And do I want to take out another bicuspid up here? Well, the answer to that is no, I don't. Now on this side over here, yeah, I can take out a tooth on the top and I can close the space on the bottom and be great. But if I don't do the same thing on the right, her midline is going to move in that direction. So, you know, we could have made compromises. We could have just replaced the teeth that she's missing. We could do a bridge here. That's roughly about $1,000 a pop. Every time we do a bridge, it's $1,000, $1,000, $1,000. So it's close to $3,000 for a bridge, and she would need 2 of those. An implant, $3,500, $3,500. Or I put a $250 anchor. I can take out a tooth on the top, on this top left. I can close the space on the bottom. Her lips could come back anyway, and treat her just like I would anyone else. So basically, if you take a look here, you go from initial treatment to 9 months to 13 months. You're seeing the space close. You're seeing the space. I want this cuspid to fit right in this groove between these 2 teeth, just like it does up there, just like it did at the top. Here, basically, my top teeth were moving back more than these were. So I had to slow it down, because this tooth, this tip is supposed to fit in this groove. This tip is supposed to fit in this groove. It was coming back too fast. So I had to slow it down a little bit, and basically we got all said and done. The anchor's still there, and basically she's got a good occlusion. We end up here. Now, granted, she's got stains and she smoked it all while she had braces, and that's definitely not good for the aesthetics of the teeth. But she can get her teeth cleaned and do some aesthetics, aesthetic bleaching and some bonding, and make that look a little bit better. But you know, orthodontically, we were able to overcome some things that we used not to be able to do in the past. These are. This is an orthodontist in Japan who was lecturing at the AAO a couple years ago, and I borrowed some of his slides. But basically, he was showing how you can intrude teeth, which is something we never thought we could do. We never thought we could intrude teeth. We would, you know, in this type of case, you want to do an implant back here. You have no clearance. So how do you do it? You'd have to extract the teeth up top, or you'd have to cut these teeth back so much you'd have to do root canals and crowns on them to be able to get clearance. Because orthodontically, we didn't pull them up. We had nothing to do, no way to do it. Well, with anchors, basically, you can use anchors and you can intrude teeth up to get clearance for your implants. And he shows quite nicely how he's been able to move those teeth up to be able to get clearance for the implants on the lower, so that he can have a nice restoration. There's lots of different ways to do it. You can use anchors on the outside and inside, lots of gadgets, but they're, you know, once again, nothing magical about them. It's just a platform to give us a direction to pull in. And just some more cases where it just shows the ways that people had set them up.
I have a question real quick.
Sure.
Sorry. When you're moving that tooth up, do you just mean you're like pushing it further into the gums?
Well, if you think about the socket of a tooth, the tooth's not actually connected to the bone. It's in a sling with a periodontal ligament. And as long as you have a periodontal ligament, you can remodel the bone, because when you push on it, it melts the bone in front of it, and it pulls on the ligament behind it, and the tension stimulates bone growth to grow behind the tooth. So when you move a tooth in this direction, you get resorption in the front and apposition behind it as the tooth migrates through the bone. Well, if you move a tooth up, same thing. you know, it gets smaller here. As you move it up, you get resorption up here, and as it moves up, the socket kind of follows the root. So as you move it up, though, the gum tissue usually will go with things. But if you move it up enough, then the gum tissue kind of gets baggy over the teeth, and you have to go back and trim some of that away. But when you move the tooth down, the gum tissue comes down with it. Going up, if you move it up a long ways, then sometimes you have to get a laser or remove the tissue, or have somebody remove the tissue. And this is just a bunch of different spiller shots from this past year. This is him throwing the pass at North Carolina State game. This is Florida State, some fans action. This is that was from the ACC championship, and this spiller, that's another one of the helmet shots. This is a patient that I finished not too long ago. This is a multidisciplinary case. Basically means that it's not just orthodontics. And he has seen an orthodontist and an oral surgeon in Anderson, and they had talked to him about doing treatment, and they had talked about doing jaw surgery because basically there was no real way to move these teeth up. They overlapped the bottom teeth too much, and he only had one posterior tooth back there. So unless you've got some control, you're not really going to be able to move the teeth up. So they were going to open them up surgically, open the bite surgically so that they could straighten the teeth and do the restorative. Because these teeth were all broken down, worn down, and they were going to bring the lower jaw forward. Now, granted, there were some things that would have been improved with surgery, but the patient was absolutely not going to do surgery. And so he avoided treatment for years. And his dentist in Pendleton sent him to me. I had done a lecture about with this at Anchors at it's Dental Society that's in this area, and he knew a little bit about it, and he brought this case to me and said, what can we do here? And the reality of it is that he does have a front to back problem, but his biggest issue is a vertical problem. And so I used some anchors on the top, and I used those to move the anterior teeth up. Because normally we'd use the back teeth to help lift the front teeth up, but we couldn't do that in him, so we used anchors in the front to intrude those upper incisors. And you can see how they're different heights here. And it's because I'm really lining up the gum heights, because he's going to have crowns on pretty much everything. And basically, you don't line up the edges, you line up the gum heights, and then they add back that part with restorative material. But so we look at him here, and he's set up for the restoration. This tooth really should fit in this groove, so there is a front to back bite issue. But it took us a while to get him to here, and that's there's some things that you pick your battles, and it wasn't going to do surgery, so sometimes you can't correct everything with just orthodontics. You have to have some help. And over here, these teeth are tipped forward, and we didn't totally upright. These are temporary bridges. That's a plastic bridge with a wire that's built in. Just because I needed some, once I got those anterior teeth up, I needed some posterior vertical support. I needed some back teeth touching so that I could finish my orthodontics. And basically, with him, we were able to open him up, and he's getting close to $30,000 worth of dental work, bridges, crowns, implants. And what would have surgery cost? That would have been another $30,000. So he would have had to have orthodontics anyway. Basically with 2 anchors, we were able to avoid doing surgery. This is actually my treatment coordinator. You probably saw her when you came to the office. And I had treated her once before. And when you look at her, she's a very pretty girl. But there's something wrong with her smile. Anybody pick it out? When you look at her facial picture and you look at her smile, what do you see?
The lip seems lower.
What?
Her
Teeth
lip.
don't overlap.
It's like,
The lips lower on this side, so you see a cant there. That's going to get you a Kit Kat.
yes.
Okay. She has a facial asymmetry. She has soft tissue asymmetry. So we look at her facial asymmetry, you're going to see her eyes. She has something called hemifacial microsomia. Half her face is smaller than the other half. So if you take a look at this side, it's shorter than this. Your eyes are dry. I mean, she's a pretty girl. I hired her. But she's very good at her job too, by the way. But she's got a facial asymmetry. Her occlusal cants from her interpupillary line. Now she also raises this lip up higher. Now what are ways we can handle this? Surgery. With the upper jaw up on that side. So there's some bone issues there. Soft tissue wise. Some Botox right there. paralyze that, paralysis processorius, basically the elevator muscle here,